Today we have Dr. Andrew Ibrahim. He's a practicing surgeon and healthcare delivery researcher whose work focuses on AI implementation, care redesign, and operational improvement across health systems. We also have Dr. Justin Fraser. He's a practicing neurosurgeon and stroke specialist who led the development of a statewide stroke collaborative supporting rural hospitals across Kentucky. Together, they bring firsthand experience designing and scaling neurological care coordination models that help rural hospitals expand access to specialty care while keeping more patients close to home. With that, I'll turn it over to our speakers and we'll get started today.
Great. Thank you so much, Cody. Great to see so many of you. I may be a familiar name to some of you. I've written a number of papers on critical access hospitals, notably demonstrating that they often provide surgical care on par with their urban counterparts, especially for common general surgery. So my bias in my own clinical practice has been there's often things that we can do locally really well, and we should try to optimize that. And that's sort of the headline of the talk today, where we'll talk about, can AI be a meaningful tool that helps enable us to do that? I know there's a lot of collective interest and maybe angst about what is AI, what does it do? And so our goal of this session today is to try to just show like a real world example of a tool and just practically the nuts and bolts of how it got implemented and what that was actually like on the ground. And I'll give you a little context of the problem. This is a cascade where many of us, if you work in the emergency room or in the hospital, maybe know all too well that when a patient presents with stroke-like symptoms, there may be a dozen people that need to get organized to be able to get them to the right place for care. I know about 2 years ago, my father was having stroke-like symptoms, and as he was en route to the hospital from the ambulance, I started thinking, oh my gosh, who are all the people that need to know? Now, I'm a clinician who works in that health system. So I called the radiologist to say, hey, be a lookout for the scan. I called the emergency room. I called the transfer coordinator, because if you need intervention, you have to go to the other side. And not everybody has a son with tacit knowledge and the pager numbers of the people at the hospital to organize care. But safe to say there are plenty of patients who can get lost for hours in this whole process trying to get to the right care. So the innovation that came about a year ago was, could AI actually screen CT scans in real time and within a minute or two identify, does this patient likely have a stroke that needs intervention? And the beauty of it was not just to identify it, but to notify all the people in that pathway so that even the person at the end of that communication chain who may need to do an intervention, who may need to get the patient transferred to their center, is already now coordinated in a single chat and has the images in front of them. So this was one of the first really canonical stories of how AI can improve healthcare delivery, first approved by the FDA and put into practice in 2018, and now widely used at almost over 2,000 hospitals in the US. There have been almost 100 peer-reviewed papers written just about this AI example: faster time to treatment, reducing length of stay, because when patients get treated sooner for stroke, they recover faster, increasing access. There are many patients who could recover from a stroke if they got the right treatment, but that treatment's time dependent. And so if we can get them to the right treatment faster, they get access to the right treatments, then ultimately better clinical outcomes. I'd say that headline that is not on this slide is the title of this talk, which is that when you first hear this and see this, you think, gosh, am I going to lose all the patients in my hospital because they're not all going to get triaged at a bigger center? And the reality is more than 90% stay local. I know that for many of you, also top of mind is just thinking about this once in a maybe generation opportunity around rural health transformation programs. And you could almost make a case that a tool like this aligns with all five. Certainly sustainable access, innovative care models, and technology. But I've had a lot of talks with different states and different providers saying, gosh, how much more excited and willing would a provider be to come spend more time at our center if they knew they were supported with some of these AI tools? So I'm going to pause there and hand off to a friend and colleague, Dr. Fraser, who's been living this for the last 8 years, and no questions are too small or too candid. He's lived the work and implemented this stuff, the good, the bad, the ugly, all things in between. And to give a little context to Dr. Fraser before he starts, Cody, maybe we'll do our first poll question, which I think is like an interesting, sets the tone for the environment many of us are in, which is, on average, let's say you have that stroke patient, someone who you think, gosh, they need to go to a higher level of care that's time sensitive. How many places do you have to call before you can start to settle on the right place? And we'll give that a minute to tally up.
Yeah, absolutely. Thank you. I do see some votes coming in. I'll leave it open for a little bit longer so we can get some more. And your options are just one. Our first call is usually accepted. 2 to 3 hospitals, 4 to 6 hospitals, 7 or more, or I'm not the person who handles this.
It's not on there. You can also choose, I wish I was not the person who handles this.
You can drop that in the question panel. We'll definitely watch it.
But so you can start to see some of the frustration in the numbers. One person calling 7 or more hospitals in a time sensitive scenario. So I know the pain, I feel it. And I think that's a good segue to hand things over to Dr. Fraser, practicing neurosurgeon at Kentucky, who's built a remarkable program to fix exactly some of the problems this question surfaces. So Justin, thanks for being here to share your wisdom.
Thanks so much for having me today. So I'm the vice chair of neurosurgery at UK, and I'm the director of cerebrovascular neurointerventional here as well. But we were in a position where basically we're centrally located in Kentucky. We are a metropolitan area per se, but we serve a huge catchment of several million folks who stretch all the way across the main body of Kentucky, over to West Virginia, down to Tennessee, up to Ohio. And many of these counties are rural-based counties that have maybe a critical access hospital, and since some of them may have only 2 ambulances for the entire county. And so figuring out how to take care of stroke patients has been a constant ongoing challenge for us in our environment. So time is brain. We know this. About 1.8 million neurons are lost each minute, and the probability of a good outcome goes down by 10% for every 30 minutes that you wait until they're treated. And so this is the United States and stroke death rates. Kentucky's in the belt buckle of the stroke belt. We have Appalachia completely taking up the eastern portion of our state. And that's where people are at most risk of poor outcomes in our region, at least, because of the lack of good access to care. This is a problem that we all know about, that has been published on and ad nauseum. The next slide really demonstrates the lack of reach of time-sensitive transport, right? So Lexington's right there. The 1 to 2 hour drive range doesn't even cover half of our state. And so we do rely a lot on air power, choppers, to get us patients. But this is a big challenge. And that challenge only stacks on top of the issue of recognizing a stroke, recognizing whether it's in an interventional stroke, something that we can do something about, and then triaging the patient appropriately, which involves using resources that are really critical to these counties. So this has been mentioned. What we're looking at here is Viz.ai. So the idea here is wherever Viz is, we are. Right. And so if the hospital, whether it be our comprehensive stroke center, the primary stroke center that's an hour south of us, or the acute stroke ready hospital that's 2 hours from us, or the critical access hospital that's 3 hours from us, if Viz is implanted into their CAT scanners and they work with us, those scans can be done within minutes of arrival and sent to our phones. And in fact, while I've been sitting here, this is my phone, my personal cell phone. While we've been sitting here, I've gotten 3 Viz alerts. Now, I'm not on call today. I always keep it on for myself because I'm the director of the program. But my partner has been answering them while I've been talking to you. And so let's say critical access hospital 3 hours away does a CT scan on a potential stroke patient. Those images come to my phone. I can look at them just as that picture depicts right there. We can actually respond to the team directly in that emergency room to say, hey, I reviewed the pictures. There's a large vessel occlusion stroke, or there's no large vessel occlusion stroke. And so this allows us to really triage stroke patients in real time. It's not a replacement for telehealth. It's important to designate that, but it does the critical heavy lifting of figuring out, do we need to get this patient on the road to a larger stroke center or not? And you can tailor that based on where you are. So obviously, how we work with a primary stroke center might be different than how we work with a critical access hospital in terms of the interest in keeping and the capability to keep certain types of stroke patients there. So we started this with the idea of improving patient outcomes from ELVO stroke. We wanted to see a growth in our regional hospital stroke programs. We wanted to implement basically this AI-powered tool to detect large vessel occlusions and then improve the interhospital communication. Nothing breaks trust more than you have a doctor who's working at a rural health community center. They call us up for a transfer. We say, it sounds like it's going to be a great case. Please send it our way. We're going to do a thrombectomy. We're going to do this procedure. So he goes and tells the family that they're going to the big hospital up the road an hour to get this procedure. And then the patient shows up and they're not a candidate for some reason. And then we have to tell the family that we're not going to do a procedure on them. That really creates a very disjointed sense of care that breaks family trust. And so we really wanted to be able to look at these patients, triage them, and say, hey, they can expect when they get here, they're going straight to the angio suite. And so that really, and be able to give that feedback to the outside hospitals. So the benefits here, obviously, are rapid identification of ELVO, multi-institutional interactions, getting us to work with our community providers. And it helped us to grow as a hospital, as well as to get our interventional faculty kind of out and seen by these outside hospitals and recognized so they know who the providers are. So this is where our experience began. We installed Viz in 2020, just as the pandemic was hitting. And we started the organizational workflows once the machine installation was done. So basically it gets installed onto your CAT scanners. And then we started a workflow build and eventually activated it around July. So it took us a few months. It's important, I think, not to rush that process. You want to go in a very detailed way when you do this. Certainly, we've helped other hospitals onboard Viz ourselves. We're happy to help any way we can. So I didn't put this up here. It's very small. I didn't put it up there for you to digest the details, but rather to see the workflow we built. And if you look, basically a patient comes in, gets a CAT scan, the scan gets sent, and then you'll see all these little squares or rectangles down in that lower area. And they're all different people who are logged on to Viz. So I logged on to Viz, my on-call neurointerventionalist is logged on to Viz, our on-call stroke neurologist is logged on to Viz, our residents are logged on to Viz, and our bed coordinators are logged on to Viz. So meaning the bed coordinator sees the chat. They can see the chat that's going on between myself and the outside hospital emergency provider. And so when I say go, when I say transfer for thrombectomy, that's it. There's no extra phone calls, there's no backs and forths. The bed coordinator will sometimes say, please take a picture of the patient's face sheet and pop it into the chat. That's it. And the patient's on their way. So it took just the triaging time alone really gained us a huge amount here. So when we first started, this was just the first few months of us going live. We were processing anywhere from 197 all the way up to 170 scans a month. And we were urgently reviewing, meaning the Viz kind of said, hey, there's a problem here. You need to look at the scan between 20 and 30. Now, our workflow is unique in the sense that I love Viz and I love the AI engine related to it, but I insist that all of our neurointerventionists, whoever's on call, looks at every CTA that comes through and makes some kind of commentary. We try to do that within 15 minutes of the scan being performed. So the reason I put this slide up here is to show you the importance of communication. So the Viz engine is not just a remote radiology evaluator. There is the HIPAA protected chat portion. And that is as important as the imaging itself. And what I'm showing you here is the light blue is the number of patients in each month. The dark blue is the number of chats back and forth. And so there was a lot of discussion about certain patients, figuring out should the patient come directly to our emergency room. Sometimes we'll say, hey, that's not a large vessel stroke, but that's something we need to see. Why don't you have them come to our clinic in 2 weeks? So we're literally triaging the patients into different destinations. And that's really important both for utilizing appropriate hospital transport resources like ambulances. It's important for providing patients continuity of care, and whenever possible, keeping those patients in their local and regional hospitals, which actually, as I'll show you shortly, is quite possible. So in our first full year of activation, which is 21 to 22, granted we were coming out of the pandemic at the time, we evaluated just shy of 5,000 CT non-con head CTs and 1,600 CT angiograms. We detected 237 LVOs, and our average response time, for over 99% of our time, we were able to respond within 5 minutes. So we weren't waiting for our radiology read. We weren't waiting for anybody else. We would see the scan and respond. And we actually, what's interesting is we saw an improvement in our own door to revascularization time during that same period. Now, granted, we didn't really change anything else about our process here at UK. And so that just having the Viz really helps speed things along, not just in terms of your triage transport, but in terms of how you get patients in. And a lot of that time is saved because if the patient had imaging at the outside hospital, had a CTA, we're happy with it, the patient's clinical condition didn't change during transport, we usually don't even do any scans. We take them straight to angio. And so that has had a huge impact on our own metrics. This data, I have to say, is outdated by about 4 months. This data is about 4 months old, so the numbers are probably higher. But just to give you an idea, from 2020 to early 2026, we've looked at 17,000 patients. We've transferred 1,100. So that's about 6.6%, meaning most patients we did not need to come.
Justin,
And
maybe I'll pause us here. This might be a good segment to do our second question for the audience.
Sure, no problem.
That if you think about, if you had sort of something like this in place, it doesn't have to be stroke specific. It can be any acute condition, pulmonary embolism, it could be a heart attack. If you had that kind of infrastructure in place, how many transfers could you potentially avoid per month at your hospital? I'll say anecdotally, while the numbers are going up, I was born in the UP of Michigan up in Houghton and then came down to Ann Arbor, which is where my clinical practice is now. I probably get called at least once or twice a day of somebody that they maybe want to send down. And often it's the case that if I can just see the CT scan alone, I can say, hey, that's probably okay to stay there. Or they can come electively, but don't need to do the ambulance or the flight. And pretty remarkable here to see almost a quarter of you identifying 6 or more a month. That means every week there's maybe a patient who could stay locally if you had the right information exchange infrastructure in place. Pretty incredible.
Yeah, for sure. And I think this really demonstrates what we found as well. Some of our larger stroke centers that we worked with did have a decent process in place. But what was interesting, and I'll show you the data in just a minute, is even the places that we already had established relationships with really showed benefits in their own stroke metrics, and we can talk about that. But to your point, many places we see this play out in real time where many patients were staying. We've had several of our hospitals in the last 3 years that used to be critical access hospitals or something small community hospitals now go for acute stroke ready hospital certification. One even went for primary stroke certification because they were able to keep a lot more of their patients locally. And so they were able to actually build a real program. What we've seen, and the data really show this, and certainly we're not the only ones who've seen it. These are publications that have been put out on this. This type of technology can really help reduce burden of futile transfers, patients who don't need to come because of ability or we can't do anything to help them. And then it also increases the transfer rates of appropriate thrombectomy patients. So patients who never got treated but needed to come. And now we're seeing a more honed, if you will, triage system for true ELVO patients. And that's key. And that helps to patients get treated faster, better, and have better outcomes. So this is some of our own data. So on the dark blue on the right, those represent our minute times for each of these categories before we implemented Viz in the 2 years prior to Viz implementation. And the ones on the left represent now. So the first one was our imaging to transfer acceptance, meaning if a patient comes into the outside hospital, they got a CT, rule out stroke, it was an ELVO, what from the moment the scan is done to the moment we say go transfer the patient, we've gone from almost an hour down to 20 minutes. We see the same improvement in door to decision. And the last one is one of the metrics that Get With the Guidelines makes you track, one of the metrics that the Joint Commission wants you tracking, which is door in, door out time, meaning from the moment the patient rolls into the emergency room in the regional hospital to the moment they roll out to head to the stroke center. And so that one is a difficult one to improve because there's so many variables that go into determining that time. But even in that variable, we saw almost a 30-minute improvement just with Viz alone. This is where we stood basically in our own center. So this was our own center. So if for those who are in comprehensive stroke centers or thrombectomy stroke centers, you might be saying to yourself, hey, this kind of technology, it'll help me recognize strokes out there and get them here. But it's not going to have a big impact on what we actually do, if you'll pardon the expression, at the big house, right? But we actually saw improvements across the board for us as well. So we saw a 15-minute improvement. We went down to 5 minutes if the patient's here in our own house. And then our improvement in imaging to access, I say groin stick, but I should replace that because we do almost over 50% of our strokes now through the radial artery. And then improvement in imaging to first pass, which is a crucial Joint Commission guideline and metric. So we're seeing improvements in our own institution. It's also impacted the growth of our stroke program. Like I said, the data tells us that now we're getting more of the appropriate patient to our stroke center. So you can see in 2016, we did 37 thrombectomies. In 2023, we did 235. I just got the data back for this last 2 years. We're now over 300 a year in terms of thrombectomies performed at UK. And I really, having that rapid access to Viz, you could see the numbers were similar down in 2018, 2019, and then they keep going up as we move forward. At this point, we have 42 hospitals feeding into our Viz feed. So it's also created an opportunity to improve how we interact with our regional community collaborating hospitals. So we provide, as I said, we provide the messaging and the feedback. So not only do they tell us, hey, there's an ELVO, okay, we say transfer. Once the case is done, we can go right back into that same messaging task and say, hey, we did the thrombectomy. It was one pass. We got it fully open. Thanks for your help. And so getting that feedback back to our regional healthcare providers, I think it's crucial because it tells them the importance and the impact of the work they're doing. We got our own data analyst, and I can talk about how to make that possible in an ever-changing world where cost reduction is necessary. But we got our own data analyst to work on this with me, and she puts together quarterly dashboards for each of our referring hospitals, which I'll show you in a second. And we have participated as the Comprehensive Stroke Center. I've participated in other hospital Joint Commission reviews because we can bring the Viz data, show it to the Joint Commission, and they love it. And so this is an example of one of our quarterly dashboards. Now I've removed the hospital, each hospital that we work with gets one of these. I've removed, obviously anonymized this one, but you can see we show them their different time epochs from pre-Viz to post-Viz. We show them the number of patients they transfer for thrombectomies. We also sometimes find things on Viz that are not thrombectomy but need to come, call that higher level of care transfers. So ruptured aneurysms, AVMs, moya, these kinds of things. But you can see, again, we show that over 96% of patients were staying at their hospital. So in conclusion, from my end, this AI tool really has improved our stroke care epics, our intervals, our metrics, if you will, of time. It's improved our interinstitutional collaboration with each of these other hospitals. It's allowed us to safely and reliably be able to say, hey, that patient can stay in their regional healthcare center. They don't need to come here, which reduces transport resource utilization, makes that next ambulance available for the patient who really needs to come, and has allowed us to share data and learn more about our own patients. So I'll stop there. Thank you.
All right. Thank you so much, Justin. I hope that was sort of just a candid view of what's involved in implementing something like this. And as Justin alluded to, it's an exemplar because it was one of the most critical time-sensitive conditions to start with. But you could imagine replicating it across anything with imaging, or frankly, just sharing the imaging or any other time-sensitive condition. There are corollaries to this with EKGs for heart attacks. Or do you need to activate the cath lab, or is this unnecessary? Why don't we open it up to questions?
So first question to come in, what is your triage process for all these facilities, especially screening for false AI positives?
Like I said, what we do, to your point, there are false positives with AI. Absolutely. And I like it that way. I'd rather that the AI catch everything than ignore something. So I have no problem with that. But what we put in place was we try our best to have a neurointerventionalist review every CTA that comes in. I can't guarantee the non-con head CTs just because there's so many of them. But the CTA, every CTA that pops up on our Viz, we try to look at. We have a stroke nurse coordinator at our comprehensive stroke center. Most of them do. This is the person that usually goes with each patient when they arrive in the ER, makes sure that the TNK is getting in, is writing down all the times. That same person has Viz on their phone, and one of their jobs is to track times. So if a Viz.ai, if a CTA pops up, they start a timer, and if 15 minutes go by and they don't see a response from us, they start calling each one of us to provide that response. So say I'm on call and I'm in a procedure, one of my colleagues can answer the Viz. So that's how we do that triage, and it has worked very well.
I'll add like one technical note about that too, is obviously every hospital is unique and every CT scanner is unique. And so as part of a quarterly check-in, if a site feels like, hey, you're calling too many, or maybe you're not calling enough, we can actually fine tune the AI models to increase the sensitivity. I'd say most of our sites are like Dr. Fraser, where they would rather err on the side of flagging a handful of too many. And then when the specialist looks at it, says, oh, this one's okay, as opposed to maybe undercalling and missing a couple. So it's something that's dynamic that we tweak with every site every quarter.
Thank you both. And Julie, thank you. She said ditto to your response there to Dr. Fraser. So I think everyone is in alignment there. Another question, how many neurologists do you have at the Comprehensive Stroke Center who review the Viz notifications?
So our actually aren't the ones, it's the neurointerventionalists. So the folks who actually do thrombectomies. We don't ask our neurologists to do it. They can look at they have access to Viz, they're communicating with us, but the decision-making process is the neurointerventionalists. Here at our UK, we have 4. There's 3 of us that are neurosurgeons, 1 that's a neurologist. We also have 2 fellows, and the fellows are involved as well. And essentially, whoever's on call is responsible for Viz. But if they're in a procedure, then we all kind of chip in.
And I'll say maybe for contrast too, there are some sites, UCSD is a notable one, where their neurology group, the neurologists are very active in this platform. So they're actually reviewing all the things in real time, and they love it as part of their relationship with the interventionalist. So they, just another example, are a little more neurology heavy, but ultimately the interventionalist probably needs to be involved at a minimum. And then some sites also include some of the other care team members in that decision-making process. But ultimately you could add anybody. In one example, there's a site that has the helicopter transfer coordinator on the alerts. And from that, they're picking off does our helicopter need to be sent out soon? So they're monitoring that as well, tailorable to what the needs are at the site.
I have a lot of questions coming in, so I'm going to try to get them
Great.
in the right order.
Right.
I believe this is an add-on to the last question. Julie says, so does each site have a stroke coordinator?
All of our stroke hospitals have a stroke coordinator. So if you're an acute stroke ready hospital, a primary stroke center, a comprehensive stroke center, you have to have a stroke coordinator. But not all of our hospitals that are on Viz are TJC recommended or TJC certified stroke centers. So the short answer is no. But if you are a TJC center, then you have a stroke coordinator. Those stroke coordinators are not involved in the daily Viz. On the outside of the hospital, like in the outside hospitals, the folks responding to us are often either the nurses or the physicians or APPs in the emergency room.
Thank you for that. So another question, can Viz help calculate an ICH severity score?
Yes, there's a separate module for ICH that you can certainly use that has, and to Dr. Ibrahim's point, I've spent the better half of, or pretty much all of our talk today, at least my talk, talking about ELVO stroke. That being said, as I mentioned as a side note, we often see things on Viz that are not ELVO, but still need to be addressed. And so it is a very useful tool across all of the breadth of their disease, at least for us. We often catch subarachnoid hemorrhage, ICH, subdural hematomas, and we address those patients as well. But the main driver for why we started the process was ELVO.
Thank you so much. Another question from Sonia. Sonia says, for rural hospitals that do not have resources or grant writers for state assistance and have transfer agreements with a CSC that already utilize Viz, what suggestions could you provide that have aimed to be successful to have rural hospitals gain access to?
I can speak to that from my perspective, but I think Dr. Ibrahim may have other thoughts as well that are useful. So we probably want both of us to weigh in. You do have to be a little careful. And so at least in our state, and this may vary, and I would encourage comprehensive stroke centers to talk with their own group about this. At least in our state, we explored whether or not our hospital could essentially pay for the Viz for our referring hospitals, and that was not allowed. Our risk management folks thought that would be kind of borderline stark violation, and so we decided not to do that. However, I think there's a lot of opportunity on the Viz side. I think I'm probably not the best person to address that directly, but I know that they have worked with different levels of hospitals at different stages in terms of how to get Viz effectively into their institution. And I'll probably may know more about that than I do.
Yeah, I'd say there is like some state to state variability and institutional variability, but we certainly do whatever we can to lessen any of the burden on the rural sites, and the rate there significantly lower, many X-fold than it would be at the hub site. The other thing I'll say that I think related to that is if you already have something like this in place and you're like, gosh, this really helps us for this, and you identify another thing, gosh, I really wish we had this for CTs of the chest, or I really wish for this face fractures, I could get that site to look at it. Please reach out to us. We spend so much time with our sites. We're on the ground all the time. We often can do a good job of sort of matchmaking to say, hey, this site who you're already helping triage stroke has a large burden in this condition. We can share that information on our platform. Do you also have a clinical champion at your site? Once we have the infrastructure in place, it's a lot easier to add different disease conditions or different modules. So I would say where you have the biggest need, reach out to us and we can help you with the matchmaking part.
Okay, thank you so much. Another question, how do you convince your group of neurointerventionists to use this technology?
That's usually not a heavy lift. Most neurointerventionists are well aware of this kind of technology, just because in our space, it kind of got started in our space, and many papers have been published using this kind of technology. And so most are pretty well aware of it. And my general experience with people who work in my field is that we want the information fast and we want to get the cases in. And so it really is not a heavy lift. I think where you do need to work together is understanding how are you going to respond to the Viz alerts and creating workflows around that so that not one person is shouldering the entire burden of that.
I think one thing that maybe I'll just double click on is like the general surgeon on the call too, that I think is unique is proceduralists love to read their own images. If I'm going to take someone to the operating room, I'm not really relying on what the final radiology read, et cetera, necessarily was. I like to look at the images myself and make my own decision that I can sleep comfortably about. Neurosurgeons the same way, interventional cardiologists same way. So I think one thing that really resonates with the end user is to say, hey, I'm going to put the images in your hand along with the context information and ability to talk to the group. And that's been really attractive to the users.
Great, thank you. Andrea says, how have you dealt with lack of EMS transport resources to get the patient to the comprehensive center? We have transports that take hours to be picked up after the decision to transfer.
Yeah, that's a separate discussion, and I feel your pain. And what's really scary is it varies tremendously county to county. We've got counties in Kentucky that the EMS providers are very engaged and very worried about the time it took to get the patient from their hospital to us. And they are keeping the metrics and they show up fully armed with all the information. And those are amazing. We also have counties in our hospital where there'll be one ambulance service and they'll often refuse to take patients out of the county because it's raining. Unfortunately, that's often a very local issue because of how EMS is constructed throughout the United States. What I would say and what has been successful for me has been identifying the problem sites, identifying the opportunities, and going out to those folks and actually like presenting directly to those EMS houses. Once they see the data, you're engaging them on a personal level. And I really think that can be extremely helpful, especially in cases where you're having trouble.
Yeah, I'd say, and if you are a site that has this in place, it's pretty readily easy for us to pull the data. So we could pull the number of times something's been requested, hasn't happened. I've personally found state health departments to really be responsive if we put data in front of them and say, hey, there were 20 patients in the last 3 months at this hospital who needed transfer, and there was a real rate limiter and they had a time sensitive condition. Oftentimes it tends to be an anecdote of one or two and it gets brushed off. But when we put a number in front and say, it was this many people at this site, they are much more responsive. It's partly why we built a helicopter button into the platform, because there were sites where ambulances weren't practical, and collaborating with state leadership said, all right, this is going to be a site that also can have access to helicopter services. Let data lead the way.
Thank you. We did have a comment, and thank you, Rochelle. She just mentioned that getting the folk hospitals to really use the clinical info and chat helps a ton too. So thank you for that. I have another question that's kind of built off the last one, but I think it's important that we go ahead and address it because I think you can provide some real tips here. How did you approach, Dr. Fraser, how did you approach change management and clinician buy-in as you rolled the AI alert system out? Was the approach the same for both frontline staff and radiologists?
Okay, just to make sure I understand the question, are you asking about how we rolled it out to our clinical management staff, or are you asking how did I convince the administration to buy into this?
So I believe it's all of the above.
That's an hour.
Excellent. I'll take the first one first. So the clinical buy-in was pretty easy because we all saw the data and our neurology staff were interested in not caring for unnecessary transfers. Our emergency room was really interested because they are constantly overloaded, and if I could reduce their burden, that was easy. I think figuring out how to utilize creating those workflows that I showed you, that took some meetings, and the folks you want in on that meeting are the physician champions, whoever they're going to be. You want your stroke coordinator. We also have a liaison, like it's essentially the liaison that does a lot of the emergency room liaisoning with outside hospitals, who is participating. We have our lead nurse our chief nurse for the neurosciences inpatient, and we have our data analyst. And that's kind of our core group And that we still meet monthly to go over data and discuss things, even been doing this so long. So I think that's an important method for building this workflow. As far as the administration goes, we went to them, we showed them the pricing structure, and then I turned around and I told them, hey, if I can grow our stroke thrombectomy volumes by this many, we paid for the system. And by the way, this many is only like a couple of cases. And they were interested. And then when I came back at them each year and said, hey, we grew our stroke volume by 100 cases. And oh, by the way, we reduced the transfers of stroke patients by 93%. Those are numbers that they got their head around. And so they've been pretty solid champions of the program ever since then.
Yeah, I'll add, so my formal training is health services research. That's my master's degree, 200 papers studying health econometrics. So I've actually built a planning tool where we could simulate any hospital in the country, putting a platform like this in place and being able to give the health system leadership their estimate of what this would mean for clinical impact, for improved length of stay, for change in procedure volume, for savings on futile transfers. Once that data is put in front of them, it's usually very compelling. And they're like, oh, wow, okay, that's very meaningful to our system. And then in terms of radiologists, many radiologists love our platform. They use it slightly differently. There's a version of it that integrates right into PACS. So actually, while they're sitting there reading dozens of scans, the ones that are flagged by Viz will go to the top of their queue, and they'll be like, oh, this is worrisome, time sensitive. And so they're moving it to the top of mind, while concurrently their colleagues in neurosurgery and neurology are also reviewing. We've had a lot of great feedback from radiology teams, including teleradiologists as well.
All right, Dr. Ibrahim, I think this one's for you. How does this model support the CMS Rural Health Transformation Program priorities you referenced? Where would you point a rural hospital that wants to explore funding support?
Yeah, this is great. And feel free, by the way, my email and phone number is there. I'm a little old fashioned. So if you just want to talk on the phone, you can text me and I'll call you back at my next break. But I would say the two areas that have come up the most are around access to specialist care, including chronic conditions. CMS views stroke as a chronic condition. So when you see the things about diabetes, heart conditions, pulmonary, they see stroke in that same family. So chronic condition care is certainly true. The hub and spoke relationships have been some of the biggest emphasis. And I've been fortunate to work with a number of states now and a number of hospitals applying for state funding. And so I'd be happy to work with you and look at what the specific state RFPs are asking for. But this type of platform aligns incredibly well for reasons that when you walk them out become very clear, because when you initially go to a state and say, we can identify patients who need this procedure, they say, gosh, that sounds expensive. You're gonna have a helicopter, then you're gonna pay Dr. Fraser to do this thrombectomy. But what's the counterfactual? The counterfactual is that patient doesn't get that procedure, and now they're in long-term rehab for months, if not years, because they didn't get their stroke intervened, and that's far more costly. The state and CMS and RHT, there's a very compelling cost savings argument. And as Dr. Fraser alluded to, this becomes self-sustaining pretty quickly, that after RHTP money runs out, when the system's up and running, it should more than cover itself so that both the rural hospital and the hub can maintain it afterwards.
All right, thank you. So I do have another question for Dr. Fraser. How did keeping more stroke patients at spoke sites affect program growth?
In terms of their program growth, it accelerated it. So we had several of those hospitals now going for TJC certification and as either acute stroke ready or primary stroke centers. And we help them do that. As far as our own program goes, we were busting at the gills and have been since before COVID. And so really it allows us to take care of the patients that we're supposed to take care of as a comprehensive stroke center, which is the most complex, the patients that need real neurosurgical case, treatment, et cetera. And so it's helped us to, if you will, achieve the kind of networks that the Joint Commission really wants to encourage. And that's been helpful for both.
So one more question that came in for Dr. Ibrahim, from a health system leadership perspective, what made this hub and spoke model replicable across multiple facilities instead of getting stuck as a single site pilot?
Yeah, great question. And thank you for that. I think one of the things that we didn't touch on today that's becoming more and more the norm is when this technology first came out 7 or 8 years ago, if you could do it for one condition, it was like, holy smokes, this is amazing. Of course, we want to do it. However, there are many conditions this can be done for. And health systems now are saying, I don't want to implement a tool for one condition, for one pathway, because now I got to hire 50 new vendors, 50 new sets of contracting, et cetera. So we've built out our platform to more than 50 FDA supported clinical pathways, just like the one that we showed you around stroke. So now when we go to a health system and say, we know you heard about us through stroke, and that was our origin story, but we now work in cardiology, oncology, and more broadly in radiology and trauma. It's made it much more enticing for the health system to say, hey, we're willing to do this first one with you because we know if it goes well, you can help multiple other service lines, and we don't have to do a new MSA, a new governance committee, et cetera. And so that has been in our favor, that we've continued to grow our platform so that health systems are more willing to adopt it.
Okay, thank you. I've got two more questions. I hope we can get
Sure.
some. For a hospital administrator at a smaller critical access facility, what should they plan for in terms of internal resources, staff time, and workflow redesign to get a program like this off the ground?
As far as the cost of the actual installation and maintenance, I will leave that to the folks in Viz. But you don't, from an outside hospital perspective, most of the collaborating institutions we've worked with, they haven't hired any additional FTEs for the program itself. There's a cost associated with installing the hardware and beginning the process with Viz. Once that process is in place, the hospital itself, to my knowledge, doesn't actually do the maintenance on the Viz itself or anything like that. It's just maintained. And that's kind of it. And then there's an educational piece that goes with teaching the emergency room providers and stuff to utilize the system and how to utilize it. That is, we do that as the Comprehensive Stroke Center. We do that. We provide that education to the folks that we work with. So what I would do if you're in that situation is reach out to the Comprehensive Stroke Center you plan to work with. And often if they're using the platform already, they should be able to provide you with an education. And worst comes to worst, I recorded essentially what amounts to a little webinar YouTube video on how to use the actual software efficiently. So I always happy to share that.
Yeah, we found that infrastructure onboarding pretty straightforward and pretty low lift. So I'm happy to follow up with you afterwards, and we'll try to squeeze in the last question.
All right. So this has really been great information today, but what is the first right step?
The first what, sorry?
Right step.
I think the first step is a little different depending upon what kind of hospital you are. So if you're a comprehensive stroke center, I would say gather your troops and contact Viz, and they can come and talk with you about it and start that process. If you're a smaller community hospital, where you make sure you have someone to send the scans to. Identify, if you don't already have one, identify a comprehensive stroke center that you can work with, and then make sure that they already have the system in place. And then essentially you can contact Viz, and they'll start working with you on putting it in your shop. And then you just designate them as your hub, and that's really how it goes.
Yeah, I'll add a little just detailed double click on that. I think identifying a problem that really matters and resonates with your site, I would feel awful if we spent a bunch of time, a bunch of resources implementing a thing, and then it doesn't help you at all because you don't see that condition. It's not a need you have. You're right. So being internally thoughtful about, hey, this is a real pain point. If we could address this thing, everybody here would be happier. And then we just need, in addition to that need identified, one champion. It can be a clinician, it can be an administrator, somebody who becomes the point person at that site to say, hey, we're going to come out for a training. Can you get people together for lunch next Tuesday? Hey, we need to look at this feedback loop of data. Can you get on a call for 30 minutes? And we really just need one person, and that goes an incredibly long way to get this up and running and operationalized. And I'm always happy to chat anytime. And I'm not shy to say, hey, this maybe isn't a good fit for you too. So don't feel pressured or bashful if you're like, I don't want to talk to Andrew and sign up for stuff. I'll be pretty candid if I think it's not a great fit, but for many sites, it really is and really helps them advance their care forward.
Thank you so much, Dr. Fraser and Dr. Ibrahim, for all the information today. I'm going to hand it back to you for closing remarks, and then I'll end us today. I do want to say Viz.ai is a NRHA pipeline partner, and their support in rural healthcare does help make sessions like today possible and our upcoming conference. So thank you so much for being a partner. I'll turn it over to you.
Thank you so much, Cody, and thanks to NRHA. I've been going to the meeting for over a decade now and have been incredibly impressed by how willing everyone has been to share their experiential knowledge over what's working and what's not. And I hope to bring that same spirit and commitment. And so feel free to reach out independent of stroke related things, even if it's not, we're just like, man, we're getting all these questions about this AI thing. I'll do my best to help you figure out what the right thing to do. I feel a sense of urgency that these AI tools are really valuable, and we really just need to get as educated as possible to make sure we're adopting the right ones in the right place to impact us. We don't want to look 5 years from now and say, man, we spent a lot of money and blew it. And so I'm all in to try to figure this out to make sure we get it right. I'll leave things off to Justin.
Yeah, thanks so much for having me today. Our process, we developed over time. It was a team effort, and it's not, we've definitely hit bumps in the road, and we still continue to do a lot of review and revision of it. But if we can help you in some way, just let us know. We're happy to help. I'm happy to give you the info. I'll share freely our experience at any time. Thanks for having me today.